Antonio, it's so good to see you. Really glad you could be here with us today. If folks haven't heard of you, Antonio Ciaccia, you've made your rounds on podcasts and articles and advocacy for really kind of understanding the what I would like to call the hidden economics of drug pricing. There's a lot that goes into that, obviously. But yeah, if you just want to take a minute and introduce yourself, this is obviously our podcast, Frontier Briefing, for a very Montana audience. So a lot of these issues are national, but I think that we get some good stuff out of it. So take it away. Tell us a little about yourself and how'd you get into this in the first place? It's kind of a niche area.
Yeah, I'm a recovering drug pricing dummy is the way I would say. Son of a pharmacist. My dad worked in hospital pharmacy for about 40 years and worked at an independent pharmacy on the side. I wanted to be like dad. I started working as a pharmacy technician for a regional grocery store up in Cleveland, Ohio for a few years. I went to pharmacy school, hit organic chemistry and said, pharmacy sucks. I don't want to do this anymore. So I switched to journalism and political science. And just when I thought I was out of pharmacy, I got pulled back in. My second job out of college was working for the Ohio Pharmacists Association, where I got to learn about drug pricing from the arguably biased perspective of pharmacists. Pharmacists want to get paid more for what they do, whether they deserve to or not. But what you could see above the pharmacist was more and more money going into a system with less and less money necessarily making its way out. And that kind of set me off on a little bit of a journey as everybody was complaining about the rising cost of pharmaceuticals. It became very apparent to me that most people didn't actually know how medicines were being priced and how the flow of dollars worked through the drug channel. So fast forward the tape, I am now begrudgingly a drug pricing nerd. And I run two organizations, one called 46 Brooklyn Research, which is a nonprofit that is dedicated to taking publicly available data in the drug space and teaching it in a way that would be usable to an otherwise layperson. That was intended to be a hobby that bothered my wife between the hours of 9 p.m. and 12 a.m. And eventually we were asked to start doing legal work for law firms that were litigating in the space. I launched a consulting firm in 2019 called 3Axis Advisors, where we do work for everything, provider groups, advocacy groups, Medicaid programs, Medicare plans, health insurance companies, industry disruptors, state auditors, state attorney generals, employers, all over the map. But really trying to do what we can to demystify what's happening in our prescription drug supply chain and identify the hidden cost drivers that maybe shouldn't be there in the first place.
Yeah, no, it's funny you bring up layman because I think, I'm also a policy wonk. Mine happens to be more of like the zoning variety and like tech policy, which is a whole other can of worms.
Very exciting.
I know, right? It's my fiance. She's similar mentality that like, why are we talking about this at dinner? But what I was going to say is when I was researching kind of a little about you and your work and all the things that you've done, I intentionally tried to not get to like the very bottom or the very end of some of these podcasts and episodes because I wanted to try to approach this from kind of a more of a layman perspective. So some of my questions might be a little bit more high level, but I think this is such a important area for people to understand, and it can be so intimidating. So kind of just to start out really high level, you had a really great quote talking about drug pricing is one of the most dysfunctional marketplaces in the economy. And from your vantage point, what's uniquely broken about it? Why is that the case?
I think you're dealing with two unique challenges. One is a patent system, right? Meaning that in the United States, as a means to try and incentivize drug companies to bring new innovative products to market that can hopefully make us better and ideally reduce costs, we provide essentially a monopoly through patents and tell that drug company, look, thank you for bringing something new and innovative to the market. Here is a patent that will give you essentially protection in the marketplace to reap the rewards of that new innovation. And it comes with a timestamp on it. At some point, that drug goes generic, and essentially the marketplace gets the secret sauce, and competition can grind down the actual price of that previously innovative drug. That's a good thing, right? I think in general, that is a healthy thing to give drug companies. And in general, I like the churn of branded generic drugs. We can maybe quibble over whether we need patent reform or that whether or not the system is working as it should. But directionally, I think that is a very good and healthy thing. Well, anytime you're dealing with essentially a sanctioned monopoly, you're going to have problems with essentially that whoever it is that's providing something of need taking liberties with price in the marketplace. And on the other end of the spectrum is the fact that because we have agreed as a society that our wallets and purses won't buy things at the pharmacy counter, but instead we will rely upon intermediaries to essentially work on our behalf. We don't have a typical consumer-driven market. In a typical consumer-driven market, whoever is selling a product or a good, whether it's at a retail, store or somewhere online, not necessarily medicines, ultimately, whoever is selling that product must make sure that the end price is sober and enticing enough that we're willing to pull out our wallets and buy that thing as a means to maximize profitability and sales volume. When you're talking about medicine, something that could be life or death, and when you're talking about putting an intermediary in there that might be a health insurance company or a pharmacy benefit manager, well, now all of a sudden it's other people's money that's buying something, right? And that's not an inherently bad thing, but it has an intrinsic impact on distorting what should be an otherwise more efficient competitive marketplace.
Mm-hmm. I think you're spot on there. Especially something that we like to say here at Frontier Institute is prices communicate information. And, a lot of people kind of tend to overlook that, what that price is telling you is, should I buy more of this? Should I save? What are the things going in to make this? And I think that's why your quote is so poignant, is that we just don't know. Is it the insulin really cost that much to make? Or is it that there are so many people in the middle? And so that kind of brings me to my next question to be, is this a distinctly American issue of this pricing with drugs, or is this in other places? Give us a little snapshot of what that might look like around the world.
Well, I mean, every country has to grapple with this challenge of a drug company making something that is so important for people within the marketplace that for true one of one, meaning like a true innovator product of which there is no substitute, the manufacturer, regardless of the marketplace, has a tremendous bully pulpit, right? That, hey, I'm going to charge what I want, and if you don't like it, you're going to have to deal with it. You're not going to get that medicine. That problem, it manifests itself in different ways. In the American marketplace, we're willing to spend more in general. We have a more liberal approach to regulation of the marketplace. One of the things that, even though market demand might be similar in some ways in other countries have taken the more common approach of making a heavy hand on price. The governments go to the drug companies and say, if you want to sell your drug here, this is going to be the price. Sometimes that means drug companies will delay access for a medicine in another country or won't even provide it at all. What it means in the United States is we have more choice, we have greater access, and we pay the price for that because we as a country have essentially stipulated that we are not going to have a heavy hand of government that will dictate price. And so that does not make America unique on its own. The other thing that makes it unique is that in other countries, while they might have one price for a drug, in the United States, we have agreed to essentially have a very disparate environment for price, meaning that Medicaid programs will get the lowest or the biggest discount off of a price of a drug. And then we'll have other government programs get discounts as well. And then we'll have exemptions to federal anti-kickback laws to allow PBMs and insurance companies to get rebates from drug companies. And so you have this perverse system in the United States where instead of competition actually working to lower the price of drugs, what competition does is it actually creates an arms race to the top. Manufacturer incentives and pharmacy incentives are such that they should inflate prices more and more over time to create bigger and bigger discounts underneath, with results varying on who gets what discount under all of that.
That's really interesting. Is that kind of where 340B program comes in and kind of like the base prices? Will you explain a little bit about that, of how they get the biggest discounts there?
Yeah, so years ago, we had the creation of the Medicaid drug rebate program. For those unfamiliar with exactly what Medicaid is a federal program, but ultimately carried out by states. And it is a program intended to serve the health needs of essentially the sickest and the poorest in the United States. So you meet a certain, economic or financial threshold, and you qualify for Medicaid coverage. So think of it as the poorest of poor. Well, before Medicaid covered medicines, you had this problem that we were providing healthcare benefits to the poor. But as we know, medicines are integral to ensuring you stay out of the hospital, and medicines can actually prevent you from going to the hospital in the first place.
Right.
So there was an acknowledgement that, okay, if we're going to cover health services for the poor, we need to expand coverage for medicine. So very good premise. As the government sought to expand this entitlement program, whether we agree with the philosophy of providing those benefits in the first place or not, they went to drug companies and said, look, we're going to do something that's amazing for you. These poor people who can't afford your drugs, we're going to make it affordable for them. We're going to cover these medicines with no strings attached, essentially having no patient cost sharing obligations. And we're going to make drugs that otherwise were not affordable to people absurdly affordable. They'll be free, basically. Well, drug companies saw that as a great opportunity, right? We want people to have medicines that otherwise couldn't afford it. And they were willing to essentially do anything to make that happen. So as a trade-off, the government said, okay, manufacturers, you're going to give us a massive discount on these medicines in exchange for us covering them. In fact, you're going to guarantee us that of any discount that you offer in the marketplace, you will extend it to every Medicaid program in the country, a best price obligation. So you had a mandatory 23% discount, a mandatory best price or a most favored nation clause for Medicaid drugs, and you had inflation penalties, meaning if a manufacturer raised prices beyond rates of inflation, they would accrue more penalties on top of that. I know all that sounds like a lot, but think of it this way. The Medicaid rebates are so substantial that there are instances where a manufacturer will rebate the entire list price of a product back to a Medicaid program.
Wow.
So if I have a $1,000 drug list price, I could have to pay $1,000 to Medicaid or more every time it is dispensed in that program. Well, when that happened, all right, there was a big clamoring. Hospitals who were previously getting the biggest discounts said, oh no, now these discounts will have to be honored for all Medicaid programs. So now we're afraid that our discounts are going to go away. So the hospitals did what any good lobbying group does. They go to Congress and say, hey, let's create this new program so that the Medicaid discounts go to us too. And so the 340B program was created with the idea that manufacturers will provide deeply discounted drugs to select hospitals, FQHCs, clinics, et cetera, so that they could get them, buy them at low prices, sell them at very high prices, and pocket the difference and use those dollars to fund otherwise uncompensated healthcare services.
So effectively, like price controls is kind of maybe a really simplistic way to look at how it started. Capping the price or mandating discounts over here. Is that a decent way to describe it? Obviously, it's way more complex than that.
Yeah, the thing I don't like using the word price cap only because the manufacturers can charge whatever price they want.
Right.
What these programs did was mandate discounts. So think of it this way, it's a hidden tax, right? If you tell the manufacturer you have to give something away for free or do it essentially at a loss, whether it's to the Medicaid programs or the 340B programs, well, these are publicly traded companies. They're not charities. So ultimately, any sort of giveaways will be priced into the sauce. So if I'm a manufacturer and I know that 15% of all sales will go to Medicaid and maybe another 10% will go to 340B, well, I consider that all a loss. So I need to make sure I take a more liberal approach with the list price to make sure that I have enough bandwidth underneath it to give all those discounts and rebates away.
Now, some of those discounts are very clearly like required by law. Other ones are there not, or is it just kind of built into the model at this point where you have to have a high enough price that you can offer discounts?
Basically, all government policy over the last few years has been not centered on lowering prices, but instead getting discounts off prices. So think of your, fill in the blank department store, an 80% off sale at Macy's, or the Bed Bath & Beyond coupon for 20% off no matter what, right? These are not benevolent coupons and endeavors. They're essentially pricing distortions, and they're meant to communicate essentially, a falseness of a deal. Well, in the drug channel, at the end of the day, if everything is bought by either government programs or insurance companies and PBMs, the pricing will reflect the demands of those marketplaces. So you have Medicaid getting big discounts. You have 340B getting big discounts. You have the Department of Veterans Affairs getting discounts. You now have, under the Biden administration, the Inflation Reduction Act, which now expands government mandated discounts through Medicare. And you also now have exemptions to federal anti-kickback laws so that PBMs don't have to pay the list prices for drugs, and insurance companies don't have to pay the list prices for drugs in the commercial marketplace, but instead drug makers are able to give legalized kickbacks in exchange for covering those medicines. You throw all of these things into the proverbial stew, and the manufacturers have almost zero incentive to compete by lowering the actual price, but instead to create higher prices and bigger discounts. The challenge for us as consumers, whether you're a small employer or a sick patient at the pharmacy counter, is it is impossible to experience a sober, rational price in the marketplace without the government mandating that discount or having to work through a conflicted intermediary in order to access that reasonable price.
Yeah, it's a tough situation for consumers, I would say, for sure. Like, how to navigate this is, is already really confusing. Now, you mentioned specifically most favored nations. Is that kind of we've heard a lot about that in the last, year or so, maybe further back even than that, most favored nation pricing. So is that kind of in line with 340B? Where's the overlap? What's the difference, if there is one?
Most favored nation pricing, at least the way it's being bandied about today, is the idea that other countries, other industrialized nations, have lower list prices for drugs than we have here in the United States. And it's true. As I said at the onset, one of the reasons is those governments take a heavy-handed approach to say this is the price that will be allowed, and there's trade-offs when that occurs. But the second challenge is that it's not an apples-to-apples comparison. Everything I just told you is that we use inflated list prices to fund other priorities. Mm-hmm. So we use inflated list prices to provide disproportionate benefit to the Medicaid programs. We use inflated list prices to provide subsidies to our hospitals. We use inflated list prices to give big rebates back to PBMs, insurers, and employers as a means to lower the overall premium for covering health benefits in the first place. That's not an excuse for high prices. It's just the reality that the U.S. demands high prices or incentivizes high prices because those prices are not ends in of themselves. We seek those prices to fund other priorities. Other nations, A, set the price, and B, don't have essentially this subsidy scheme that lives underneath them.
Mm-hmm. Theirs is in some ways maybe a little bit more direct. Ours is kind of hard to follow. We're using like the discounts here and the savings to offset a public good over here in another program. So this kind of brings you kind of touched on it, but I'll put some maybe explicit words to it. The concept of vertical integration in pharmaceutical supply chain. Can you maybe unpack that and its role? I know you've talked a little bit about it here already, but maybe more explicitly for our audience would be great.
The idea of vertical integration in marketplaces is not an intrinsic evil. The idea being, hey, I own a hardware company. I'm going to essentially have my own products that I sell at that hardware store. Those things can provide efficiencies to the end consumer. But given some of the dysfunctionality that I mentioned in the drug channel, vertical integration can become a double-edged sword. Mm-hmm. In the US, outside of the government getting involved and putting their thumb on the scale on discounts, most of us procure our medicines through pharmacy benefit managers or PBMs. Conceptually, they started in the 60s as basically when we started covering pharmacy benefits under benefit plans. They said, hey, we need somebody to process the claims. So if the patient comes to the pharmacy, we essentially have a Visa or MasterCard like experience when covering those medicines. Over time, as more and more drugs got covered under benefit plans and as more and more expensive drugs came to market, we started to look to PBMs and say, look, rather than just pay the bill, maybe you can start using your intelligence and your sophistication and leverage to start negotiating the bill. And so the idea became, well, hey, drug companies are raising the prices. They sell drugs to wholesalers. They want to raise the prices. And they sell drugs to pharmacies. They want to sell the prices. And whether the marketplace was fair or not at the time, people that bought medicine said, well, maybe we can use these PBMs to act as a counterweight or a friction against one side of the supply chain that wants to take whatever liberties they can with those prices. That was a good thing. And eventually PBMs started opening their own mail order pharmacies to say, look, we don't like the amount of competition in the pharmacy marketplace. We'll have our own mail order pharmacies that can be an option to provide good savings under these benefit plans. Very reasonable. The challenge is that like any publicly traded company, these are not engagements in altruism. So they ultimately said, look, this thing that used to be a loss leader, we can start making money off of it. And since we, the PBM, gets to say which pharmacies will be in our networks and which ones won't, we can start creating a favorable environment for the pharmacy that we own and start disadvantaging the pharmacies that that pharmacy competes with. We, the PBM, can actually start buying our own insurance companies. We, the PBM, can actually start owning our own specialty pharmacies. We, the PBM, vertically could start employing physicians who actually write the prescriptions. And so since we, the vertically integrated company, also get legalized kickbacks from drug companies, we can put our thumb on the scale either through formulary design, pharmacy dispensing, or physician writing prescriptions to find ways to generate more and more profits off of one conflict of interest that we have with our drug companies that we're supposed to be fighting,
Right.
but are actively getting paid by at the same time.
Yeah. So that friction point, maybe not so much friction after all these years.
Friction became grease. And so the challenge of the drug channel is we don't have a PBM problem, right? We have a larger problem of drug pricing inflation, right? And an over-reliance on intermediaries to insulate us from those inflated prices. The PBM problem is uniquely bad because the system as designed relies upon their purity. And so long as the police are getting paid by the gangs, or the firefighter is the arsonist, right? The system pressure that we rely upon is compromised when the PBM has a vested interest in prices going higher, not lower.
Mm-hmm. Yeah. I mean, I think that kind of brings up before I get to the state level, I guess I should kind of unpack what's the federal update. Obviously here in Montana, we're quite a ways from DC. What are the reforms being pitched, both maybe good and bad from your perspective, maybe good and bad from my perspective as well? Just give us a feel for what's happening over there.
So the challenge with DC is that there's schools of thought that government should get involved, shouldn't get involved, right? It's healthcare. Guess what, guys? We're screwed. It's already government is in healthcare, period, end of story. There are a lot of problems in the PBM marketplace, mostly related to those conflicts of interest, where essentially they want grease instead of friction. Well, a lot of the mentality around what I would call PBM reformers is let's ban this practice, right? Or let's better align the PBM incentives so that they can do what they are tasked with doing. And I think a lot of that is reasonable. Like at the state level, we've seen successes there. And if the goal is to create more efficiencies in drug spending, if the goal is to enable broader access to medicines, then maybe those approaches, if you agree with the philosophy of government intervention and outlawing certain practices, maybe there's opportunity to kind of refine things so that PBMs could be restored to their origin. You have antitrust efforts by the Federal Trade Commission, where they're essentially going after PBMs for some of these vertical integration conflicts and some of the coalescing of the market in ways that antitrust law was meant to prohibit. But the thing that I'm most interested in, and I think is still missing, is the idea that maybe we don't need these inflated prices in the first place. Maybe instead of actually trying to tell PBMs what to do and what not to do, there are things that we can do to make the transaction more straightforward, more transparent, and less inflated in nature, thus decreasing our reliance on PBMs instead of having them be essentially an essential toll booth in order to access rational pricing in medicines. To give you an example, there are independent pharmacies across the country, Blueberry Pharmacy in Pittsburgh, Freedom Pharmacy here in Columbus, Ohio, Mark Cuban Cost Plus Drug Company nationally, where they're operating outside of the confines of the legacy system and are essentially operating in a cash model where the distorting influence of insurers and PBMs and rebates and all this stuff are gone. And what you can see is that those pharmacies that have nowhere near the size and sophistication and leverage of the largest PBMs are able to provide lower prices than the legacy system or the intermediaries who are supposed to be leveraging their might to create them. So I would argue that those are good indications that a functional marketplace is possible. And so rather than just saying get rid of PBMs or ban these things that PBMs do, I would argue that perhaps a better approach would be to store traditional fundamental economics into the drug channel and get rid of some of the distorting influences that are causing prices to inflate in the first place.
Absolutely. And I think, we've have some of those pharmacies here in Montana too, that are just solely cash based. And we've done some price comparisons. And it's really impressive, quite frankly, what can happen when we get rid of all of the middlemen kind of taking their cut, arguing with each other, going rebates back and forth. It is pretty amazing. And, that's kind of where we've been of, obviously we are more of a free market orientation. And so our view is that when government gets involved, things get really messy. And the tendency when government gets involved is to have more government get involved to solve that. And then it gets more government to solve that. And then it just gets really messy incentives. So I think from our perspective, that's definitely what we like too. So at a state level, we have a lot of legislators that listen to this podcast and a lot of leaders here in Montana. What are the things that you're seeing that are like low hanging fruit, or even maybe not low hanging fruit, things that we can work towards to tackle the issues that you're talking about?
I think there's two main buckets, or maybe three main buckets for states. One is active state attorney generals, right? The laws are on the books, enforce them. Medicaid programs are one of the biggest line items in state budgets. Every state attorney general's office has what's called a Medicaid fraud control unit. Mm-hmm. Those have been previously mostly focused on providers. They should still be focused on providers, but they need to expand their purview into the intermediaries who are supposed to be making things more efficient. So most state attorney generals are learning kind of on the fly that it's not just providers who can engage in fraud, waste, and abuse. It's administrators and insurers as well. The second thing would be, looking at those state programs. It's not just Medicaid. It's state public employees. It's state teachers. It's counties. All those things, government programs who are also being fleeced by a lot of the problems that we see in the marketplace. Montana actually has a rich history. Marilyn Bartlett, who used to be at the Department of Insurance in Montana, made a name for herself going after big hospitals and big PBMs for essentially misalignment, essentially taking advantage of state programs. The third bucket would be actual state policy efforts. My bias is less policy is good policy, but in general, one of the biggest challenges I see in the commercial marketplaces is a lack of accounting of what PBMs are doing on their behalf, meaning it's a really complicated environment, very complicated marketplace. It's intentionally designed that way. As a result, traditional laws of supply and demand and competition don't always apply. I can't tell you the number of times where I work with a state department or an employer where they say, Antonio, help me solve these problems. And I say, okay, well, let me see your contract and let me see your data. And they have neither. Right. And so how can you shop? How can the wheels of competition that we rely upon in a capitalist system work when the buyer and seller aren't communicating on equal forms of information, right? So I believe states have the easiest thing to do before getting too heavy-handed on the market is mandating that people buying drugs actually get a receipt for those drugs.
Yeah. No, I mean, I think that's, one of the biggest things in economics that you brought up a couple different times is that if you have uneven amounts of information, that causes some messy outcomes really quick. And sometimes it's necessary. Sometimes it's just kind of, the nature of the beast. But other times, especially if there's like government policies influencing that, it seems like a good area to kind of address and just to have more knowledge there. Well, we're almost out of time here, but before we part ways, I wanted to kick it over to you and let you say, is there anything that Montanans should know? Quick spiel about anything like this. Obviously, this whole subject area can be really difficult. It can be really hard for people to stay positive about. And so I wanted to just see what your thoughts were.
Yeah, I mean, the big thing I would say is look, in a very complex system, one of the things that I always strive for in all of our work is simplification. A better informed consumer and an environment of lower prices makes you, the purchaser, less reliant on someone else to get a deal, right? And to me, that is a really important fundamental that if we as policy, or if people as policymakers care about lowering prescription drug costs, right? One of the best ways to do that is not just ban X, Y, and Z, but provide the marketplace with actually create efficiencies on its own, rather than just relying on someone else to do it for you. So a more consumer-driven market, I think, is a solution, along with a lot more transparency. So when you're sitting around the kitchen table wondering why are drug prices going up, what can policymakers do about it? The shorthand is make it simpler and make the prices lower without necessarily a ton of government intrusion. Restore the fundamentals of capitalism in the drug channel, and and you'll find a lot more efficiencies than a lot of the solutions that are being ballied about today.
Couldn't have said it better myself. Well, Antonio Ciaccia, I really appreciate you being here today. Where can people learn more about you and find your work?
At the website 3axisadvisors.com and 46brooklyn.com.
All right. Thank you so much, Antonio. We'll have a little exit here.
Thank you.